So I would like to call Dr. Aditi, who will talk on cataract surgery with corneal degeneration.
forward नहीं हो रहा है slides. Very good morning to everyone here, and thank you AIOS, thank you Dr. Mona for making me a part of this, including me in this course. I will be speaking on cataract surgeries which are performed when there is a coexisting corneal degeneration. So we will be dealing with a few topics, of which the first one is Salzmann nodular degeneration. Now this is a rare non-inflammatory, slowly progressive idiopathic degenerative disease of the cornea that is characterized by bluish gray kind of nodules, which can be seen either as discrete ones or it can be seen in an annular form. The clinical presentation is variable, and the nodules can be asymptomatic or cause foreign body sensation, photophobia or epiphora. Now the pathogenesis is thought to involve poor epithelial protection. So whenever there is anything that is causing a chronic surface kind of change, then there is a disruption of the epithelium bowmans, and the epithelium derived growth factors go inside and inside the fibroblast to secrete more of the extracellular matrix. So that is when there is the development of these nodules. Salzmann nodular degeneration, the diagnosis is based on clinical examination, and topography is helpful in evaluating the contribution of the nodule to visual impairment. Now, what is the challenge when we are doing a cataract with a patient who has Salzmann nodular degeneration nodules either in the periphery or in the center? These are fairly easily treated, so you may have to counsel the patient regarding the possibility of sequential surgery, in the sense that they may need the superficial keratectomy first, and after that, once the surface is stable, although there is some amount of Bowman's irregularity which remains even afterwards, even after removing the nodules, so the patient should be counseled that they may need a sequential surgery. This is a video showing you the superficial keratectomy, which can actually reduce the induced hyperopia and the astigmatism which is caused by the elevated peripheral nodules. The epithelium is removed, and the trick is to find a plane between the nodule and the Bowman so that the entire thing can peel off, and you can then leave a smooth surface. And this improvement in the corneal contour allows more accurate and reliable keratometry for IOL power calculations. In fact, in one of the patients, permitting approximations, the required IOL power changed by a magnitude of 13 diopters following superficial keratectomy. So that is the extent to which these nodules can affect the keratometry and the IOL power calculation. So the refractive correction should be investigated before you plan your cataract surgery. And once the lamellar plane is identified and you're able to peel off the nodules along with their conjunctival adhesions, then you can apply MMC soaked sponges to the periphery where you are expecting a recurrence of the nodules to occur. So that will reduce the rate of recurrence. A multi-layered AMT can be applied at the end, so that gives you additional protection and additional smooth healing of the epithelium, so that eventually you want a smooth surface to calculate your IOL power calculations. So this is what you get by adopting all these measures. This is the preoperative appearance and the postoperative appearance. Now, like we just mentioned, superficial keratectomy can be combined with other procedures which will reduce your recurrence rate. So either you can use alcohol to loosen the epithelium, or you can couple it with an amniotic membrane transplantation, or you can use mitomycin C 0.02%. And if the patient is unwilling for all these procedures, and if it can be replaced with a simple PROS lens and give symptomatic as well as visual impairment, then you can go ahead with that also. This is a patient in whom we had performed a cataract surgery with a brunescent cataract and implanted him with a toric intraocular lens. A toric intraocular lens because the nodules were in the periphery, and although the nodules were not removed, there was only a 0.75 or 0.5 diopters of astigmatism. Next degeneration that we are dealing with is the Tyrrhen's marginal degeneration. This is a slowly progressive peripheral ectatic disorders like all the others. So it is characterized by a triad of peripheral stromal thinning associated with lipid deposition at the advancing edge, and there is neovascularization. I mean, there is a superficial conjunctival vascularization advancing onto the corneal thinning. By definition, the epithelium remains intact, and the degeneration may lead to high degrees of against the rule or oblique astigmatism. So two types have been documented, an inflammatory form and the non-inflammatory form, and both of them are characterized by this oblique against the rule astigmatism. The important point with Tyrrhen's is that perforation can happen with either spontaneously or post-trauma. So these patients have to be advised regarding protective eyewear. So cataract surgery in Tyrrhen's marginal degeneration, you can first of all, you have to determine whether the degeneration is stable, because if you're hitting a moving target, the degeneration is also progressing and you're doing the cataract surgery also, then that doesn't work. So in fact, CXL, corneal cross-linking, has been described as a promising method to avoid keratoplasty and to preserve and restore corneal structure. So you can achieve visual rehabilitation either by scleral contact lenses followed by a wavefront guided PRK. In one of the patients, in one of the case reports in literature, a sterile corneal perforation has been described while doing cataract surgery in a Tyrrhen's marginal degeneration at the area of thinning. This is a video of cataract surgery in Tyrrhen's marginal degeneration. So as you can see, superiorly, it may, in atypical cases, the thinning may be there inferiorly also. So surgery as such is a little bit of a challenge. The more of the challenge is calculating the DBR and calculating the intraocular lens power. So you aim your side ports, you aim your sections away from the sites of maximal thinning. You use all the techniques which have been already described to protect the endothelium and to improve visibility. Limbal sections are preferred rather than the clear corneal ones. And cataract surgery, other than that, is fairly straightforward. This is the way that the cylinder reduced, and the vision rehabilitation was very gratifying for the patient. Improved from a counting fingers to a 6, almost a 6/6. These are the pre-operative. The sutures, the section was closed with a couple of sutures. So in this patient, the DBR was calculated by a multiple of techniques with the auto K and the penta. Thankfully, they were all coinciding. So finally, the penta K DBR was taken and the patient was implanted with the appropriate lens. So it is important to consider the location of the wound placement and the optimization of the surgical view, the two challenges when you're doing cataract surgery in a patient with any kind of marginal degeneration, whether it is Tyrrhen's, whether it is pellucids, whether it is spheroidal. So spheroidal will also follow the same kind of rules that we followed when we were operating the Salzmann nodular degeneration. Now the next degeneration is a PMD, a pellucid marginal degeneration, again an idiopathic, non-inflammatory, non-hereditary, usually bilateral disorder which presents with asymmetric thinning. The onset of the disease is between 20 to 40 years, but it can cause severe visual deterioration because of the against the rule astigmatism. The zone of thinning, like we know, the area of ectasia is cylindrical rather than conical, and the ectasia occurs just above rather than inside the area of greatest thinning. Corneal topography classically shows the butterfly pattern. So these are the methods by which you can actually stabilize the surface for the corneal problem as such, not regarding the cataract surgery. So these are the techniques that have been described in literature for dealing with the ectasia. Management of the affected patients depends on the level of visual disability, and you can organize it according to the tectonic thing that you're planning for. Either the patients can undergo a cross-linking or intracorneal ring segments, or partial thickness LK or DALK, or a large diameter PK. The corneal independent interventions can be again spectacles, or initially RGPs, later scleral lenses. And in fact, toric IOLs have been described as a method to handle the astigmatism in PMDs also. Now these are the other innocuous, relatively innocuous in comparison to what we have already described. This is a crocodile shagreen, so the surgeries that you will be doing will be fairly regular. It is only the visibility which you have to deal with, like Dr. Mona will be describing in her surgeries with corneal scarring. This is a central cloudy dystrophy of Francois, in which you have the shagreen more in the center. So this is not a dystrophy as such which requires any kind of intervention for the corneal side. This is a senile furrow degeneration. Arcus, you have the arcus senalis deposits forming a ring in the periphery, and what is important is that there is a clear zone separating it from the limbus. So mild thinning may occur, but you can be, once you're sure that it is not associated with any collagen vascular degeneration, you can go ahead with the cataract surgery in the regular fashion. Another thing which is not strictly a corneal degeneration, but because it extends onto the cornea, is when you have a pterygium encroaching onto the corneal surface. So if it is atrophic and there's not much of fibrovascular degeneration, then you deal only with the cataract, like in this case. When there is an atrophic pterygium, but there is not much of astigmatism, then you can deal only with the cataract as such and leave the pterygium alone. But if it is affecting the, if it is increasing the corneal astigmatism, and then you need to do a sequential, a staged procedure in which you do the pterygium excision followed with the autograft and the fibrin glue, and later once the surface is stabilized, then you deal with your cataract surgery and you go ahead with your intraocular lens implantation. Oh. So now, so we will be skipping this part in which cataract surgery has been done in a patient after a patch graft. This patient was a patient of secondary Sjogren's syndrome associated with severe dry eye, and she had a sterile melt several years before she presented for cataract surgery. So she underwent a patch graft, and after that the corneal surgery, after that the intraocular lens implantation was done once she developed her cataract. So you can see the area of thinning in the periphery where the patch graft was done, and all the techniques described to improve visualization have been employed in this case also. The key is to optimize the corneal surface prior to cataract surgery and then going ahead with the intraocular lens calculations. Now patients, now we deal with the one which we most commonly see in our clinical practice, patients with keratoconus requiring a cataract surgery. Now they have unpredictable results and have an increased risk of a hyperopic refraction postoperatively. So a lot of IOL formulae have been compared, and I will be quickly coming to that. We will be coming to the intraocular lens. This was a 74-year-old male with a stable keratoconus. The most important is to ascertain the stability of your original pathology before you deal with your cataract. So we went ahead with the IOL power calculation using the Keynes formula, which is an AI-based formula. We will be discussing that later. And after that, the cataract surgery was done in a fairly regular way. What is important is that the toric IOL implantation has been done in this case once we have made sure that the keratoconus is stable and it is not progressing. As in every toric IOL case, it is important to remove the OVDs post-operatively so that the intraocular the stability of the intraocular lens can be ascertained. And here you can see that with this kind of formulae, your cylinder has come down from a minus 2.5 to a minus 0.5. Now, what is the problem with IOL power calculations? The normal biometric assumptions do not apply in patients who have keratoconus, because the relationship of the anterior and the posterior corneal surface is lost. You have an abnormally deep anterior chamber. You have a long axial length. So as it is, the intraocular lens power calculation is erring on the side of hyperopia. So you aim for myopia so that the patient ends up emetropic post-operatively. The other thing is that you do not have a regular astigmatism. Your principal meridians are not orthogonal. So you have irregular astigmatism. What you're measuring is not the accurate K, and therefore the patient is more prone for refractive surprises. Patients need to take a contact lens holiday more for rigid lenses than for soft contact lenses. Now, as far as the IOL power choice goes, monofocals are most commonly used, like Dr. Sagar has described in his talk. We prefer to use lenses with a positive or a neutral spherical aberration rather than a negative, so that can be neutralized, that can neutralize the negative corneal aberration. Patients with keratoconus have a slightly negative spherical aberration, so you want to use a neutral or a positive spherical aberration lens. Toric IOL calculations are less reliable, and but if the condition is stable, then you can go ahead with the toric IOL implantation. The rule of thumb is to see whether the patient is dependent on contact lens wear in his daily life. If the patient is dependent on contact lens wear and he's likely to wear the contact lenses after the surgery also, then you cannot go in with a toric intraocular lens, because the contact lens will neutralize the astigmatism on the corneal surface, and that leads to unmasking of the cylinder in the IOL, in the toric IOL. So you will end up with more cylinder if the patient is, and it is challenging to fit a patient who has undergone a toric IOL implantation in a keratoconus. So if the patient is dependent on glasses, you can go ahead with a toric IOL implantation, because you know it's a mild to moderate keratoconus. Multifocal IOLs, I think, is just asking for trouble in these cases, because multifocal, the results are dependent on achieving emmetropia, which you are not ideally likely to achieve. And these patients also have relatively high amount of higher order aberration. So the pearls for cataract surgery in keratoconus are that you ensure KC stability. Prior you can do either the CXL or the graft, whichever is required, and later the IOL when the condition is stable. You need accurate biometry machines for rapid acquisition, so that the tear film also does not contribute to errors preoperatively in the biometry. You need to assess the patient's dependence on contact lenses post-operatively. Incisions we have already described. Sclerals are preferred rather than the corneal. Standard approaches lead to hyperopic surplices, so we need to aim for myopia. The K in keratoconus formula and the Barrett True K KC. These provide accurate results, and you need to manage the patient expectations. So the surgical planning needs a multifaceted approaches, and these are the few reports in literature. Now the IOL formula, the K in keratoconus formula, uses a modified corneal power, and Dr. Kane has described that when there is mild keratoconus, you need to target 0.5 diopters of myopia, 53 to 59 moderate keratoconus -1. And when it is severe keratoconus, in fact, some of the papers by Dr. Watson, BJO, there's a report, you can in fact use a standard K, because there is a fallacy with all the IOL power calculations. The Barrett True K KC uses a double K method. The first K is the measured K, which calculates your IOL power, and then there is a theoretical K, which is used to predict the effective lens power. Holiday 2, unfortunately, it comes up with a lot of errors. So it's either the Kane keratoconus formula or the Barrett True K KC. These are freely available online, so you can feed in your values into them and end up with, and we encourage you to use these formulas for when you're calculating your IOL power calculations in keratoconus patients. Thank you.